Hello. Hello, everyone. Hi. Good morning, America. Good afternoon, Europe, Africa. And good evening, Asia and Australasia. This is our Isrrt first Facebook Live. And welcome friends and colleagues from around the world to join us. And I'm so excited for today's event. And we're going to have a webinar on the topic of role of radiographers and radiological technologists during COVID-19 pandemic as international perspective. We are so lucky to have 6 speakers from across the world. I will give the introduction of each speaker when it comes to their turn to talk. We have 2 speakers from each Isrrt region, from the Americas, 2 from the Americas, 2 from Europe, Africa, and 2 from Asia and Australasia. To start with this exciting event, I would like to invite our president, the International Society of Radiographers and Radiological Technologists, Isrrt President, Ms. Donna Newman, for the welcoming speech. Please welcome Donna Newman.
Good morning, everyone from the United States, and good afternoon or good evening, wherever you are from. I'm so excited to be having this first Facebook Live. I know that our members have asked for opportunities to communicate and to provide education, and the board has heard you, and they are acting on this. We hope this will become a regular occurrence and that we will be able to host opportunities of education and topics that are of interest to you. Today is the WHO No Tobacco Day, and I want to thank all our member societies for contributing to the Isrrt campaign to make our next generation of radiographers a non-smoking profession. Thank you for participating. And thank you to all our speakers that have taken time out of their busy weekend to share their experiences in their country with us. I look forward to the program, and I look forward to many more to come. So with that, I'd like to thank Napapong and Yudapong for developing this idea and for hosting this. And I will turn this back over to our hosts, and they will begin our session. So enjoy and look forward to your questions when it's over. Thank you.
All right, thanks a lot, Donna. I forgot because I'm getting excited today. I forgot to introduce myself. My name is Napapong Pongnapang. I'm the Vice President of the Isrrt for Asia and Australasia region. I come from Thailand. And สวัสดีครับเพื่อนๆนักรังสีเทคนิคจากประเทศไทยนะครับ For the first speaker, we are very lucky to have one speaker from the US, Mike Kutlas. Let me introduce Mike Kutlas a little bit before we proceed to his talk. Mike began his professional career as an instructor at the Ubangi Academy in Democratic Republic of Congo back in 1987. And after that, he came back to the US and then finished his degree in radiological technology in radiography from Mayo School of Health Related Service. And he became the director of the radiography program at Mayo Clinic, Jacksonville, Florida. And after that, he attended the master degree. At the moment, Mike joined the Isrrt, the American Society of Radiologic Technologists in Albuquerque, New Mexico, as the Director of Instructional Technology from 2008. Please welcome Mike Kutlas from the US and his talk about COVID situation in the US perspective. All right.
Hello, my name is Mike Kutlas, and I'm the Associate Executive Director at the American Society of Radiological Technologists here in the United States. I'd like to thank Isrrt for inviting me. It's always a pleasure to work with Isrrt, and it's an honor to provide a COVID-19 update on behalf of my country. The United States of America has 329 million people, and we encompass nearly 10 million square kilometers of land area. That makes us the third both in population and in terms of area compared to other countries. We're composed of 50 separate states, hence the name United States. We have a federalist system of government, which means that we have a national government, state governments, and local governments. Now, the states in the United States actually hold quite a bit of governmental power in the United States. especially when it comes to public health crises like the current pandemic that we're going through now. In terms of medical imaging and radiation therapy, there are 340,000 radiographers and radiological technologists that are certified by the American Registry of Radiologic Technologists. But there's also about another 60,000 technologists that are certified by specialty certification bodies, or some states actually certify radiographers as well. So roughly there's 400,000 radiographers and radiological technologists in the United States today. We have about 1,000 educational programs in the US that are granting a 2-year degree or above. And at any one time, there's roughly 25,000 to 30,000 students that are enrolled in programs throughout the United States. In terms of the COVID-19 situation here in the United States, we have 1.5 million confirmed cases as of today, and 93,000 deaths that have occurred due to COVID-19. Like I said, every state kind of has their own public health system, and every state is a little bit different. Here's a map of the United States. Alaska and Hawaii aren't on here, but these are the lower 48 states as we refer to them. And this kind of shows you the darker the color, the more cases are in that state. So there's some states like up here in New York, and New York City in particular, that have a lot of COVID-19 cases. So in New York, there's 360,000 cases with 29,000 deaths that have occurred so far. And that's roughly 1,800 cases per 100,000 people. But you know, New York, parts of Florida, parts of Texas, part of California, up here where Chicago is, you know, high density areas where high density population, obviously you're going to have a higher number of cases, as opposed to a rural state like Montana up here, very large state but low population. They've only had 479 cases so far with 16 deaths, which is roughly 45 cases per 100,000 people. But that's not actually, you know, New York gets a lot of attention. Some of the larger cities get a lot of attention for what's been going on, but there's actually one part of the country that's harder hit than any other part of the country. And let me see if I can get that to come up here quick. And that's what's called the Navajo Nation. This is Native peoples. They kind of have their own self-governing region here in the southwestern United States. Parts of Utah, parts of Arizona, and parts of New Mexico all comprise the Navajo Nation. This area in the middle is where the Grand Canyon is, if you've heard of the Grand Canyon. So the Navajo Nation kind of surrounds that area. But this area, because of poverty, because of inadequate resources for healthcare, has been particularly hard hit. So even though there's not a large population of Navajo in this area, there's been 4,000 cases with 145 deaths, which is 2,300 cases per 100,000 people. So in terms of the infection rate, much higher here in the Navajo Nation. Just to give you an idea of size, the Navajo Nation is about the same size as Iceland. So it's a real challenge for us in the United States to provide services in that area, but we're definitely trying. In terms of the response, like I said, every state is a little bit different, and it's really the state health departments that determine the response in an individual state, working in conjunction with the governor. So every state is a little bit different, and every state has different rules and different regulations. So where I live here in New Mexico, for example, our governor has been very proactive. We kind of shut down early before we had too many cases in our state. But even today, businesses are not allowed to have more than 25% of their total capacity of customers or employees in the building. Masks are required when you're in a building, obviously other than your home or your office with your door closed. And you even have to wear it on the street unless you're exercising. So that's a rule that our governor has put in place. Also, we have a quarantine order. So if I even left the state, if I even went to Texas or to Arizona or Colorado, one of the neighboring states, and returned to New Mexico, I would need to be quarantined for 14 days before I could be out in the general population. And even things like hotel rooms and stuff are closed to people from other states. So you tend to think of the United States as being one whole country, and it is, but each individual state right now kind of has their own mandates and their own rules and responsibilities. So how are we adapting? Well, for radiographers and radiological technologists, because there's so many differences by states, the technologists have to adapt. So it's different for every state in terms of what technologists are able to do and the pressures that are put on them. But adaptation, as I just mentioned, is probably the number one thing that technologists are having to do. So in some cases, our roles are changing. So for example, nobody's allowed to come into a hospital or a clinic without having their temperature checked and without going through some sort of a patient history. In some cases, it's the technologists and the radiographers that are doing those checks at the door before anybody even actually gets inside the building. We're using much more of a team approach, certainly in the doing portable x-rays and that sort of thing. So one technologist will be dealing with the patient, another technologist dealing with the equipment. So that way we're trying to keep the incidence of transmission very, very low by reducing the number of people that are interacting with individual patients as well. Another thing that we're having to do to adapt is in terms of hours. In some cases, the hours are long. We're trying to reduce the number of technologists that are in the clinical area by lengthening the amount of time that somebody's there, so there's fewer people, but there's still the coverage. And some technologists are not going home. They're not necessarily staying at the hospital, but there's several programs in our country with different hotels where technologists are able to get a free night or a reduced night in a hotel, or in some cases they're staying in campers or caravans so that they don't infect their families as well. So that's been a real adaptation as well. So in terms of challenges going forward, there's really three main challenges, I think, for us here in the United States. For the RTs that are in the clinical area, getting access to personal protective equipment has been a challenge in some areas and not in others. But it's very, very important that if people are working directly with patients, that they're protected adequately. So ensuring that they have access to that has been a challenge, more so in the past than it is now. And like I say, regional differences as well. Much more of a focus, obviously there's always been a focus on infection control, but right now infection control is parameters. Also educating administrators and government officials, I think, for technologists that are in the clinical area is a challenge. Making sure that people understand what we do. You hear a lot about doctors and nurses. You don't hear much about respiratory therapists, radiographers, radiological technologists, but we're certainly on the front lines providing that care. So providing education to administrators and to government officials has been a challenge as well. And accentuating the need for that personal protective equipment because we are on the front line. The second major challenge is, because there's such a low patient census, because anything that's considered elective isn't happening right now. So people aren't coming in for their mammograms, or, if their knees hurt, they're not going to come in for a knee x-ray right now. So there have been layoffs and furloughs and overall job losses. So it's been a challenge so there is some help out there, but boy, it sure came on quick. And so we've been scrambling really to be helpful. The third major challenge is in the area of education, and that's clinical sites. Clinical sites, really because of trying to protect students, because of the lack of personal protective equipment in some cases, students aren't allowed in clinical areas, and so the clinical education has had to go online, and that's been a real challenge as well. We've worked real hard on trying to provide resources for educational programs so that they can continue online, but that's been a real challenge for a lot of people. So the way forward, number one, I think, is resources, and having resources for the short term to really help people with educational programs, or with just regular education, helping to educate government officials and administrators. So what ASRT has put together is a website, like many other organizations, but if you go to asrt.org/COVID-19, you'll be able to get to this website, but you'll also be able to get there from our homepage. You can find a link to it. But we have a lot of news. We have a lot of resources, hand washing posters, for example, that can be printed out and hung up. But one of the kind of cool things that we have on here is if you click on either radiography or radiation therapy, we have a whole suite of videos that go through all of the individual procedures that would be done, your basic general procedures. Each one is about 10 to 15 minutes long. These are all free, so you can access it from anywhere. We also have a lot of webcasts. So these are all about 1-hour webinars on a bunch of different topics as well. Again, everything on this page is free. It's a lot of it is designed for students, but it would certainly be helpful in other situations as well. So feel free to make use of these free resources as well. I did talk about adapting the way that we work. That's probably our way forward as well. But really, I think the way forward for us as radiographers and radiological technologists, not just here in the United States, but around the world, is to really focus on the future. I think the real challenge in the midst of a crisis is to remember that, this is going to be over at some point in time, and things will be different in the future, but there will be a future. Whether it's students, whether it's policies and procedures, getting access to protective equipment, the education of administration and government officials about what we do, it's all important to ensure that the future of our profession is strong. Hello, my name is Mike Cudlis, and I'm the Associate Executive Director at
All right, thanks a lot, Mike, for your talk. We might have some technical difficulty just a little bit, depends
Hello,
on.
my name is Mike Cudlis, and I'm the Associate Executive Director at
Hello? We might have some technical difficulty just a little bit because of the internet connection. All right, thanks a lot, Mike, for your talk. We might have some technical difficulty just a little bit, depends on. Yes, now I would like to tell the audience that we might have sorry for the technical difficulty. But again, if you have any question for our speakers, please leave the question at the response box underneath or at the right side of the screen. We will have the Q&A session afterward. So I would like to introduce our second speaker from the Americas region. We'll have Mark Given from Canada. Mark Given is the Director of Professional Practice for the Canadian Association of Medical Radiation Technologists. And today, Mark will give us the information about the COVID-19 and the medical radiologic technologists in Canada on their perspective. Please welcome Mark Given.
So good evening, and thank you very much to the Isrrt for allowing me to speak to you today. I'm looking forward to giving you an update on COVID-19, Canadian perspective. My name is Mark Given. I'm an MRI and X-ray technologist by education, and I'm saying, so items for discussion, I'll give a quick introduction to Canada. I'll give you the current status of education, training, and health human resources here. I'll talk about the current status of COVID-19 in Canada. I'll talk to our organization's response, and I'll talk about our responsibilities and roles during the crisis. And I'll also talk about the way forward for medical imaging services in Canada. So an introduction to Canada. Canada is a very large country. We're the second largest country in the world. We have approximately 38 million people, and 81% of those live in urban centers. We have a very diverse and multicultural population. Our median age is 41.1 years. Our healthcare system is publicly funded, but there's also some private clinics, particularly in the X-ray domain and MR and CT, depending on the jurisdiction. But healthcare is provided at a provincial level, so each province is responsible for providing healthcare for their citizens. We also have 3 territories up in the north. Across the country, we have approximately 20,000 medical radiation technologists is the term that I've got there, MRTs. When I say the term MRT, it's quite interchangeable with radiographer for the rest of the world. So when I say MRT, what I mean is radiographers. So the status of education and training programs. Most of our programs have moved to online delivery for classroom education. Many of our clinical placements have been disrupted by the pandemic, but many have not. Those that have continued have expressed concern about volumes and case variety. And we move forward with our May certification, but we had to make significant changes to the way we normally do our exams, that we were virtually proctoring exams, meaning that they were doing the examinations from their home and being watched while they were performing the examinations, which is a very big switch for us. In a very short amount of time, so a very big deal for our education department to be able to pull that off. The health human resources for MRTs has been quite dramatically affected by COVID-19. In April of 2020, we conducted our first survey on the health human resources survey for COVID-19, and there was a significant reduction to the full-time equivalent status for MRTs. So when we talk about health human resources in Canada, we talk about full-time equivalent status, meaning one technologist working their full-time hours. So we've seen an overall reduction of 26% of our FTE workforce from those who responded to our surveys. Mammography and bone densitometry were the most impacted set of technologists. Our radiation therapists didn't see a lot of change in terms of their FTE statuses during this time so far. And there's been no functional areas that have reported a need for additional MRT staff. The thing that's been crushing for all of us is that overall patient volumes in imaging have been reduced by 60%. We also believe that those numbers will be higher in April than they were for the beginning of the COVID-19 pandemic as we started up. So COVID-19 has really been a significant concern for Canadians. As of today, we've had 88,000 cases and about 6,800 deaths, which is very significant. Of the total cases, the vast majority of them have been in two of our centrally located provinces, Ontario and Quebec. We also have a number of areas in our country that have not been affected hardly at all by COVID-19 and currently have 0 active cases, including the 3 northern territories, and the East Coast seems to be on its way to recovery very quickly. The biggest concern for Canadians in terms of COVID-19, particularly related to death, has been in our long-term care facilities. Approximately 80 pathology services to be offered within these facilities. The response from CMRT has been significant, and it's changed a lot since the beginning of the onset. So in mid-March, when the onset came on, we really had to switch quickly to establish remote offices for our entire staff, which we were in pretty good shape to do, but we were able to do that extremely quickly. We had to identify a lot of issues for the MRTs and what they were facing in the clinical environment. We needed to gather a lot of information, particularly around studying our members and surveying them to get a sense of what was happening in the real world. We needed to develop communications plans quickly, and we needed to modify our certification process, which I've already talked about, and we needed to start our advocacy work very, very quickly. So the roles and responsibilities for CMRT during the crisis have actually been very significant. We've had to gather a lot of evidence related to the MRT professions during COVID-19. So a lot of the stuff that I talked about related to the workforce and the volumes has been part of it, but also a lot of it has to do with access to personal protective equipment. We had to provide a lot of resources for mental health for MRTs. And we had to actually create a position statement for MRTs due to the fact that a large percentage of our technologists felt that they had limited access or weren't having the same access to PPE as other healthcare providers that were considered frontline. So statistically, as 36% of our technologists felt that they had limited access to PPE, and a whopping 60% felt that they had inequitable access compared to other frontline healthcare providers. So that was something that we felt we needed to address, and we addressed it very quickly by developing a position statement within the first couple of weeks of COVID-19. The thing is that we've had to really advocate for MRTs as frontline healthcare providers, and this has been both done at the national and provincial levels as well. There's been some progress made for adding pandemic pay for frontline workers, and we've been successful in getting that done in British Columbia, and our Ontario Association has done a huge amount of work to try and get the Ontario people invested in those pandemic pay situations as well. And we've really been working closely with government and a lot of our partner organizations in the imaging and therapy communities at large to make sure that we have a large voice for the profession as we go forward. Speaking of the way forward, the main piece of work that we've been doing around this is the Radiology Resumption of Clinical Services document that we worked on closely with the Canadian Association of Radiologists. The background on this is that it was in response to all the restrictions that have been put on diagnostic imaging particularly. The task force included radiologists, medical radiation technologists, or radiographers as you call them, medical physicists, sonographers, nuke med techs, and nuke med physicians, along with provincial data leads and agencies such as the Canadian Drug and Technologies and Health Group and Health Canada themselves. So the purpose of the report was to provide radiology service guidelines for ramping up using appropriate precautions and ensuring patients' healthcare professional safety. So this just gives you a bit of a view of the task force and how many people were involved and where they were involved from. We really felt that we needed to have a very strong perspective from all the different players across the country. And we wanted to make sure that we had every profession that had a stake in the imaging game involved. So some of the executive summary pieces that are really important is that there's going to be a lot of regional variance as we ramp services up. So Ontario and Quebec have a lot of active cases for COVID-19. A lot of our northern communities and the eastern communities have very little active COVID. So the amount of radiology services that can be resumed will be different. Capacity variations are going to be very significant. We have a lot of facilities with large waiting rooms and things along those lines that will have to be reduced for physical distancing, etc. Radiologists and the booking teams are going to have to work closely in order to triage patients to make sure that the most appropriate people are getting access to the imaging services as we wrap up. We're going to have to deal with a lot of patients' anxiety and apprehension about coming into healthcare facilities such as hospitals. Cancer screening needs to come back online very, very quickly. It's been pretty much shut down for the early parts of COVID, and we need to get that back up, or else it's going to have a significant impact on the cancer treatments for patients that have been put on hold or are waiting to get those done. And I think from the radiologist perspective and those that are making decisions about who gets scanned and who doesn't, there's going to be some ethical concerns as we go forward. So operational measures that we're going to be taking in Canada to increase imaging services is that we're going to be pre-screening patients at the time of booking and before they arrive at the hospital. Physical distancing is going to be the new normal until a vaccine has been produced or until this has run its course. And it's going to take a long time to do that. Personal protective equipment and infection control is the front and center piece for every technologist that's on the ground and therapist. Cleaning of the rooms and making sure that everything is put together is important. And communication between all the key stakeholders are the main thing. So some of the things that we're proposing is that we have radiology task force that consists of members from different divisions, being the techs, the radiographers, nurses, radiologists. Triaging is done consistently and has to be updated as we can increase capacity or have to decrease capacity if we have a second wave. We have to ensure that we have the appropriate human resources to deal with the crisis. So even when we do get back up to what is the new normal's full capacity, we do still believe that we're only going to be at 70-ish% of what we were doing pre-COVID, as long as the physical distancing pieces are in place. So a lot of the physical spaces are going to be changed. We're going to make sure that there's contaminated areas that are separated from very clean areas, try to reduce our foot traffic, trying to standardize protocols for decontaminating rooms and such. And we need to improve our capacity for remote interpretations from the radiologist perspective, but also from a booking capacity. The less people we have in our facilities, the less likelihood we have of having additional issues. So we really want to make sure that the stress and anxiety of our workers can be managed to the best of its capacity. So we're trying to do as many things as humanly possible to get that done. I think leadership is going to be a big perspective from the technologist perspective, but also from the radiologist perspective here as well. And we're going to have to work very, very closely as teams to make sure that we're adjusting on the fly and moving as things go. And as we bring technologists back into the fold that might have been laid off or taken out of the workforce for a temporary amount of period of time, we're going to have to be very, very patient with them as we go forward. So I'd just like to thank you for your time and wish you all the best with your recovery efforts in your countries. Thank you so very much for your time. Your recovery efforts in your countries.
Hi, thank you. Thank you so much, Mark. And again, we had already two speakers from the Americas, one from the US and one from Canada. If the audience now, we are so excited, we have getting close to 300 live attendance at the moment. We have like 278 and more to come. And please share this to your friends so that they know what's going on at the moment that we have the Facebook Live. For those who have any question, please leave your question on the comments box so that at the end during the Q&A question, I will ask the question on behalf of you. Our next speaker is from our Asia and Australasia region. Since the timing is very challenged for our colleague in Australia and New Zealand, so because it's very late for them, we have a speaker from Australia, Alexandra, and she's a radiographer at Royal Adelaide Hospital in Australia. Alex is passionate about CPD and student engagement, currently acting as a member of the Isrrt, the ASMRT South Australian Branch Committee, and the RAH CPD Committee. She enjoys the problem-solving aspect of working in a major trauma hospital, and in her spare time, Alex is keen cyclist and avid reader. So please welcome our colleague from Australia, Alexandra.
Hey, my name is Alex Shellerman and I'm a radiographer from Adelaide in South Australia. This is my little presentation for the Isrrt, just talking about the role of radiographers and radiological technologists during the COVID-19 pandemic. And this is our Australian perspective. So I'd just like to start off by acknowledging that the land I'm on today is the traditional land for the Kaurna people, and that I respect their spiritual relationship with their country. So I've started off with just a quick introduction to Australia. Australia's population is currently just under 25 million, with a population density of around 2.35 people per kilometre squared, although the majority of Australians live in one of the 5 major cities along our coast. During the COVID-19 pandemic, our low population density and timely international border closures have placed Australia in a favourable position to control our pandemic. Australia has a taxpayer-funded national healthcare system known as Medicare, with free access to healthcare for all. There is a high standard of healthcare across Australia, with hospitals in all metropolitan and regional centres around Australia. There's also systems in place for Australians in rural and remote regions to travel to regional and metropolitan centres for healthcare if the service is not available in their region. In terms of the current status of education, training and manpower in Australia, there are 11 universities that offer radiography, and that's either as a 4-year undergraduate or a 2-year master's degree course. Those courses have both academic and clinical components. And as of 2018, there were 12,136 diagnostic radiographers, 1,145 nuclear medicine technologists, and 2,404 radiation therapists. And I myself am a diagnostic radiographer. So here's a little bit of a spiel about the current status of COVID-19 in Australia. I did check these numbers just before I recorded this, so hopefully they're as up to date as possible, but it changes so fast that I'm not always sure. So Australia has 7,173 confirmed cases of COVID since the pandemic started, with 6,582 people recovering from the virus and 103 confirmed COVID-related deaths in Australia. We are really fortunate in that our testing rates per population numbers are really high. So we've got about 48.79 tests per 1,000 people. And at this stage, there's been about 1.3 million tests performed on Australia's population. The maximum number of new cases that was reported on any single day was 460 new cases on the 28th of March, with numbers subsequently declining to the low teens and currently like in single figures. Of the confirmed cases, only 730 have been locally acquired with no identified source of infection, which is about 10.3% of total cases. The vast majority of cases were acquired overseas, with international arrivals now required to self-isolate at the port of arrival for 2 weeks. And my current city, Adelaide, has actually only had 2 new cases since the 23rd of April. So we are in a really, really fortunate position at this stage. And this is just a little graph that I grabbed off the Department of Health website. So this is our curve that we flattened. So you can see that peak there that was kind of late March, that's really flattened out ever since, and yeah, looking really positive at the moment. So in terms of the response from our professional organisation, which is known as Isrrt, they've been really proactive in lobbying the government for protection of medical radiation practitioners and for the recognition of them as part of the essential COVID diagnostic and treatment process. Because as we all know, radiographers are frontline staff and unfortunately not always recognised as such. Isrrt also lobbied for the appointment of a chief allied health officer to be part of national leadership during the pandemic in order to have a voice for allied health on those sort of committees. Isrrt also set up a register for members who are available to work. So that might be people who are recently retired or simply taking a break from the workforce in order to match them with facilities who may be short of practitioners during the pandemic. Fortunately, that hasn't been a major problem so far, but that facility is there, and in case we do have a second wave, it may be able to be used. Isrrt has also increased correspondence with members, so there's been weekly emails with lots of information. There's been webinars on fatigue management and also 3-minute resilience videos to help members during this time. So there's been lots of resources provided by Isrrt to members regarding mental health, fatigue management, all those things that we've been, I guess, struggling with during this crazy time. So I'm here to talk a little bit about my personal experience and the personal experience I've had in my workplace. So just a little bit of context about my hospital that I work at. It's known as the Royal Adelaide Hospital. Excuse me. The Royal Adelaide, or the RA as it's known, is our state's major trauma centre, and it also services parts of the Northern Territory and New South Wales as well. So we get a massive variety of cases. We are acting as the current COVID-19 treatment centre for the state, and we have a testing facility actually at the hospital. We have a 70-bed emergency department, and we do have a 60-bed ICU also. And this is a lovely little photo of our Royal Adelaide Hospital, probably from when it was opened, which was about 3 years ago now. So I was thinking about my personal experience in terms of the workflows and how COVID looked like to our department. And I realized that there's so many big and little things that I could talk about in terms of how COVID changed our day-to-day. So I thought I would just really break it down for me. I thought, what were the 3 biggest changes for our department that I experienced from the workflow changes? So number 1 was that our emergency department was segregated into COVID patients and non-COVID patients, with all COVID patients receiving mobile imaging in their rooms. And that was done with a mobile X-ray machine that was the designated COVID machine, so that it was only meant to be used on those patients. That was confirmed COVID and query COVID as well. They were treated with equal amounts of caution. One of the big things that we did to provide timely service to those patients was we used a through the glass technique to image patients in bays. So you can actually see this image here demonstrates how we would image using our mobile machine patients through the glass. So you can see there's the little edge of a ED bed in there. That was a really efficient way that we took images of our patients, because it meant that the machine stayed clean outside of the room, and then a quote unquote dirty radiographer would enter the room with a cassette that was double bagged, place it behind the patient, while the radiographer that was clean outside of the room would position the machine and make the exposure. This was able to be used in our emergency department for patients who were in rooms with glass fronts, and it was generally really well received by radiographers, ED staff, and our radiologists, and produced really good images. One of the other big changes to our ED was there was medical resus rooms for acutely unwell or trauma patients. So often we would have patients coming in who might have been in MVAs or shootings, those sort of things, our typical patients, but there was, of course, the question added of whether or not they were COVID, so they were put in isolated resuscitation rooms where COVID precautions were fully observed. We also had a designated COVID scanner CT scanner in our ED. We are lucky enough to have 2 CTs on our ED level. And so one of those was considered the dirty scanner for those COVID patients, and they were escorted by security on and off that scanner. The second big workflow change regarding COVID in our workplace was that we moved to a model where we do all inpatient imaging performed using mobile X-ray machines. So these little Carestream DR units that are located throughout our hospital. We have 5 of those machines throughout our hospital. It was meant to reduce patient movement throughout hospitals. So for inpatients who are not considered COVID patients, it meant they could stay in their room and get imaging without being potentially exposed to COVID patients in the hospital. This meant that on a typical day shift, there's multiple teams of staff sent out to image COVID and non-COVID patients using those mobile machines. That being said, some bucky work would still be brought to the department if required, but that was just managed by the team leader who was on for that shift for the day. Yeah, so there was just a huge change in workflow for those inpatient imaging. And the third big change that we had in our workflow was that, as I'm sure many hospitals have done, there's different floors and rooms dedicated clean and dirty or COVID and non-COVID for us. So for instance, this meant that all our CT procedures were moved to a scanner on level 5, and the normal interventional scanner on level 4 was designated dirty and used for primarily COVID patients. Additionally, ICU was split in half into COVID and non-COVID beds, and multiple wards were designated as COVID only, and all of those wards were protected with swipe access. They had very, very limited visitors. A lot of those patients were in isolation, negative pressure rooms as well. So those were the 3 big workflow changes that I experienced during COVID as a general X-ray radiographer. There were many challenges that were faced by everyone in our department during the COVID crisis. There was, from really early on, of course, there was a heightened anxiety about risk of staff infection. Many of us were worried about infecting family members at home. There was lots of discussions about how people were staying clean, changing clothes, having showers at work, those sort of things. And also, with reports coming from overseas, there was huge concern about the availability of personal protective equipment to us. There was email sent out about masks and what was deemed adequate and inadequate masks, aerosol generating procedures, all of those things. So there was lots of discussions that were had between myself and my team about those things and things we're anxious about. One of the big challenges that I faced personally was that the South Australian border shut on the 24th of March, which was pretty early on. And all of my extended family are interstate. And I didn't think that that would impact me personally as much as it did, but knowing that I didn't have the option to see them was a really big, it had a really big impact on my mental health. And it was something that I really struggled with for a few weeks. In addition to those challenges, the job also became physically more taxing, particularly in that ED environment. We'd be wearing lead under PPE for hours at a time. There's lots of pictures of my colleagues coming back really sweaty from having such significant clothing on top of their normal uniform. So it did become a really physically taxing job. And additionally, when we were doing those mobile X-rays all around the hospital, there was a significant distance travelled by our staff because our hospital is quite large. So it meant that those days when you're on mobile X-rays become really, really long, imaging those patients all over the hospital. In terms of meeting those challenges head on, our management were fantastic in letting us know the resources that we had available to us to manage the challenges that this crisis has caused us. So I personally reached out. We have a employee assistance program or a counselling program available to us for free as healthcare staff. And so I certainly used that program myself to reach out and just have a chat about why I was feeling so anxious and sad, and maybe why I wasn't sleeping so well as well. I also reached out to my team leader and my management, and many of my colleagues did the same, just so that we're all on the same page. I was really lucky, as someone who is not from Adelaide and hasn't lived here this long, to have a fantastic manager who reached out to me and let me know that he'd support me in any way he could. I also have just popped in a little photo here of my wonderful colleagues. This is definitely Christmas. This is pre-COVID. Just to say that my colleagues were a massive amount of support to me, and still are a massive amount of support to me during these really difficult times. And I'm very, very lucky to have them. I felt very fortunate, very supported by them all through this time, and we are all going through it together. So I've been really lucky to have them all. I've also found isolation activities away from work that allow me to take a bit of a break from the taxing aspects of being around COVID patients all day. For me, that means reading. It means reaching out to my friends on video chats. It means talking to my parents. It means all of those things. And although I didn't use them myself, it was made clear to us that there's lots of other services that are available to us as healthcare professionals. So South Australia actually had a statewide mental health support like hotline, so you could call in and get support for free. There was also massively increased telehealth availability, particularly bulk billed telehealth availability. So for people who needed GPs, needed specialists, needed that sort of support, there was government rebates available for those. And it was also made clear to us that there was annual leave and sick leave available specifically for COVID related illness. So if staff got sick, there was dedicated COVID leave that would not be taken out of their normal allocations of sick leave. So really, really good government support for healthcare workers and the public more general as well. In terms of the way forward for our hospital, and I guess my state more generally, at the moment, South Australia only has one active case. That was actually an overseas visitor that came to South Australia. So we are incredibly lucky. We've got no patients in our hospital. We haven't had for a while because a lot of those patients were being managed at home. And in Australia in total, there's only 488 cases Australia-wide. The workflows at the Royal Adelaide have slowly been changing back to normal. Like I said earlier, the last patient was discharged on the 21st of May. So we're slowly getting to the point where our interventional HCT procedures are going back onto the normal floor. Our ED has gone back to a generally normal workflow because there's not really that many COVID patients. There are still a few, and we are still observing those precautions, but on the whole, the patients coming to the department. And I guess the next step would be getting back into that normal inpatient workflow as well. From the 1st of June, which is very, very soon, South Australia makes a move to step to the next stage of easing restrictions. So that means that we're eating at restaurants, we're getting outside, that sport is allowed again. It's really exciting. I know that a lot of the people I talk to are still really nervous about what could happen, but we are in a really fortunate position to be able to ease up those restrictions. And I just was taking some time to reflect on the positives that have come out of COVID for all the negatives that have come out of it. I know that certainly there's been a massive increase in the awareness of proper PPE donning and doffing processes and infection control. Additionally, we were all masks fit appropriately for the N95 masks, and we've had like no shortages in PPE that I'm aware of thus far. So we've yeah, it's been a really positive experience from that perspective. I feel very prepared for airborne precautions. It's also shown me that as a workforce, radiographers are incredibly adaptable and they work really, really hard. And we adapted to those new workflows really, really fast. Everyone was on board and just knew that we had to get this done to address this crisis head on. And finally, again, the camaraderie of the radiology department. Being in the department that I'm in, I'm really fortunate to have people who look out for me, who've been able to support me through all of this. As you know, it was even just those little things of we started doing things like asking if anyone needed supermarket groceries, people would grab things for other people, making sure everyone had enough to eat, that we were all in a good place. And yeah, I feel really fortunate to be part of the department that I am. So that's a bit of a discussion about where South Australia and Australia more broadly is at with COVID. I'd love to hear questions. If you want to reach out to me, please do. I'd love to hear from people all over the world. And yeah, I really hope
Thank you
that
so
everyone
much,
stays as safe
Alex,
as they
for your very, very informative talk. And I really like the information that you share, especially the way you do portable x-rays from outside the window and still get a good image. This is a very, very good opportunity that radiographers and radiological technologists from across the world to join together and share the experience during our difficult time dealing with this COVID-19 pandemic. And again, if you have any question, please leave your question on the comment box. I have seen a lot of people access to our program from across the world, from UK, from a lot of places in Africa, and especially we have quite a number from the Philippines. And thank you so much for joining us. And please share this to your friends so that they still have a chance to watch the live event as the first Isrrt Facebook Live. Let me introduce our next speaker, also from Asia and Australasia region, Dr. Naoki Kodama. Dr. Kodama is currently the professor at the Department of Radiological Technology at Niigata University of Health and Welfare in Japan. And Dr. Kodama is also our own Isrrt. He is the regional coordinator for professional practice. He is very active in a lot of Isrrt activity, especially the previous one. The most recent one that we did was on the role of the radiographers related to the artificial intelligence. All right, please welcome Dr. Professor Naoki Kodama.
Hello everyone, my name is Naoki Kodama and I'm the Director of Japan Association of Radiological Technologists, JART. I want to talk about the role of Japanese radiological technologists during the COVID-19 pandemic. First, I would like to introduce some information about Japan. The population of Japan is 127 million, and it has an aging rate of 26.7%. In other words, 30 million Japanese people are older than 65 years old. The aging rate is the highest in the world, and it has become a major social problem. In Japan, 55,000 radiological technologists are working in medical institutions. There are 32,000 Japan Association of Radiological Technologists members. Here is some information about the COVID-19 situation in Japan on May 26. The total number of infected patients was about 60,500. However, since about 30,800 patients have already been discharged, there are currently 1,800 active patients. By May 26, 863 patients had already died from COVID-19. The number of daily infected patients on May 27 had been reduced to 35 patients. There are daily cases of COVID-19. On April 7, the Japanese government issued a state of emergency in 7 prefectures. However, due to the continued spread of infection, a state of emergency was issued to all prefectures on April 16. On May 5, the government extended the state of emergency until the end of May. The red line shows the 7 days average. According to this, the peak number of infected patients was on April 15. On May 14, the Japanese government had lifted the state of emergency of 39 prefectures. However, 8 prefectures such as Tokyo, Osaka, Kyoto, and Hokkaido are not lifted in state of emergency. On May 21, government lifted the state of emergency for Osaka and its 3 neighboring prefectures. Finally, On May 25, all prefectures, including Tokyo, lifted the state of emergency. Japan's state of emergency is quite different from in other countries. A state of emergency is neither a lockdown nor a restriction on going out, but a request to refrain from going out. Therefore, there are no penalties. The government has requested the movie theaters, karaoke bar, pubs, department stores, libraries, and so on are closed. However, it has not requested that supermarkets, convenience stores, drug stores, hospitals, public transportation, restaurants, or financial institutions take leave. To COVID-19 infection in Japan, the public has been warned to avoid the 3 C's: closed space, crowded places, and close contact settings. This word may be selected for this year's Japanese Buzzword Awards. JRT issued a guideline in March of the last year regarding infection in the radiological technology field, which is very timely given the current situation. The contents of the guidelines are as follows: specific contacts for standard precautions, preventive measurement for each infectious disease, countermeasures for each infection load, environmental management of the X-ray room, corresponding manual for general X-ray, mobile X-ray, CT, MRI, IVR, nuclear medicine, and radiation therapies. We made the JART members aware of those guidelines. This is wearing and removing the protective equipment. Due to this guideline, radiological technologists' infections are very low. To my understanding, there are less than 10 members infected with radiological technologists. No more than 10% of infected people have hospital-acquired infections. So it is very low. Especially how to use PPE was explained. It was very helpful for radiological technologists. On April 21, the Japan Radiological Society notified the members of the recommendation for the radiation sector during the COVID-19 pandemic. The recommendations are as follows. First, non-urgent examination and treatment need to be postponed and reduced in number. Second, CT scan is not recommended as a screening examination for COVID-19. Third, imaging for COVID-19 patients should be performed after adequate consideration of the infections. Fourth, infection control measure is laboratories must be thoroughly implemented. Fifth, it is necessary to thoroughly implement infection prevention measurement for medical professionals and prepare a business continuity plan in case an infected person appear in the department. Six, there is a need to become familiar with the CT findings seen in COVID-19 infection. On April 24, the Japan Radiological Society also notified the guideline for chest CT examination for COVID-19. The contents of the guideline are as follows. Infection control in a CT room is essential. Imaging condition to detect the ground glass shadow can be reliably required. In principle, CT examination are not recommended as a screening tool. CT findings relation to COVID-19 pneumonia. The reason for not recommending the CT as a screening tool is present a false negative CT in 46% of asymptomatic and 20% of symptomatic. And CT scan to all patients are large impact on the medical care system in Japan. Also, the CT room does not have sufficient ventilation facilities, and the risk of hospital-acquired infection is very high. In addition, JRT magazine provides a member with radiological technologists information about COVID-19, such as prevention of infection in Spain and prevention of infection during the CT scans. JRT also shares the information with radiological technologists working at medical institutions. In particular, the place where PPE is put and where it is thrown away is very important. We have decided where to put and take off gowns and eye masks, especially in the CT room. All CT cases use disposable waterproof sheets. We also disinfect the bed after taking a CT examination. The same applies to general X-ray. In particular, the imaging table is disinfected every time. From the result of the questionnaire survey of about 15,000 medical professionals, it is known that medical institutions lack masks and disinfectant. JRT submitted a request form to the Japanese government and the Ministry of Health, Labor and Welfare. The requests are as follows: securing and distributing protective equipment, strengthening the guidance of infection specialists to protect healthcare workers, human and financial support for radiological technologists. Healthcare professionals work hard for COVID-19 pandemics, for COVID-19 patients. However, the fear and the stress of healthcare professionals is increasing. The same applies to radiological technologists. It is necessary to provide the mental health support to radiological technologists. We also need to reduce discrimination and prejudice against healthcare workers. Finally, it is necessary to consider the safety of radiological technologists while parenting or during the pregnancy. Thank you for your attention.
All right, thank you so much, Professor Kodama, our Kodama from AA region, for sharing the experience that our Japanese colleague has faced during the COVID pandemic. This is very important information that you help sharing with colleagues from around the world. And also the Isrrt really would like to thank the Japan Association of Radiological Technologists, JART, for supporting us from a very, very, very long time. Next, we want to move to Europe and Africa, and we are very happy to have our regional director of Africa to give a talk first. Boniface Yao, he represents Ivory Coast. Regarding his CV, Boniface qualified as radiographer at the National Institute of Health, training in Abidjan in Ivory Coast back in 1992, and he completed his 3 years training at University 2 Bordeaux, a University of Technology in France, later in 1993. And sorry for my French, I try to read French as best as I can here, but we all know Boniface is very popular in Africa and also around the globe. So at the moment, he holds master's degree in physics and imaging and master's degree in educational technology respectively from François Rabelais University of Tours and University of Science and Technology at Lille in France. And from December 2020, Mr. Boniface Yao has been appointed as Director of the School of Health Technologists at the National Institute of Health Training in Ivory Coast. Please welcome Boniface Yao.
Good morning, ladies and gentlemen. I'm Boniface Yao from Côte d'Ivoire. I would like to thank Isrrt to have invited me at this webinar on COVID-19 pandemic, on the role of radiographers and radiological technologists during COVID-19 pandemic as of its international perspective. Like I said, I'm from Côte d'Ivoire, and Côte d'Ivoire is a country in West Africa. In West Africa, which is a multicultural society made up by a different population coming from every side of Africa, and it is a sort of melting pot in Africa. It's also the sweet land of cocoa and coffee, and the symbols are elephant and the orange, the three-color flag. The capital city, Yamoussoukro, is the place where there's the biggest basilica in Africa, and then you've got Abidjan, the land which is the business land. The population is around 26 million inhabitants. Now, for this presentation, there's no conflict of interest related to the subject. What are we going to talk about? The outline of the presentation shows an introduction, the situation of COVID-19 pandemic, the response from organization, situation of Côte d'Ivoire, and then we come to a conclusion. The COVID-19 is a challenge for all humanity in the era of globalization. It's a world war, and the mankind faces the same enemy, which is the new coronavirus. The first battlefield is the hospital, where the soldiers are the medical staff. And to guarantee that this war can be won, we must try to see and then supply all the personnel, the soldiers, with the sufficient resources they need, which include experience and technology. To date, sharing resources, experiences, and lessons is our only chance to win. And to real cure the pandemic, the real cure is not isolation, but cooperation. We must cooperate and share experiences. And this is what Isrrt is doing. And we know that radiology is a powerful tool in medicine. And this is the main pathway to the clinical setting and diagnostic. And radiology well established with numerous high-tech procedures, which has made it notably increased in the past decades. And this results in tremendous benefit of humankind in diagnosis and treatment of diseases. But something that we shouldn't forget is that professional practice of radiology includes risk management strategies and implementation of safety culture. And that's what Isrrt has understood. And as the voice of radiation technology, well, he has developed a response document, which is the guideline for appropriate practice. And these documents, or in this situation of all the resources that are done, what is the global situation of the pandemic in Africa? What are radiography societies doing as a response to the pandemic? How radiographers themselves react towards the crisis, and what future plan they suggest for resilience. These are some main stones which need vigilance. The learning objective of my presentation are to give an overview of African Society of Radiographers initiative to manage the COVID situation as regard to their practice, to learn about specific action carried out by radiographers of Côte d'Ivoire to fight against the COVID, to reveal the challenges faced by radiographers in practicing their profession during this situation, and then to see the perspective and operation plan for better view on the future for resilience. The COVID pandemic in Africa is evolving in the region. You know that the number of new confirmed cases and deaths increasing every week, and more than half of the countries in the region are experiencing, community transmission. And why? Just that the cross-border spread of COVID-19 between countries is still ongoing, mainly attributed to the open transport of corridors of goods, which is a little bit porous, the porous borders that make people coming from one country to another. This is one of the main reasons. And we must also retain that the disease has largely affected urban population. In the rural parts, rural communities, it is just sporadic reporting cases. This means that the outbreak can still be controlled by aggressive implementation of both containment and mitigation measures. The critical control measures include active cases, finding, testing and isolation of cases, promotion of good personal hygiene practices. And these measures have been implemented diligently and comprehensively in all communities. The government, Ministry of Health, and other national authorities have put in place systems to monitor implementation of intervention. I can say that African governments have reacted, and the community themselves have been given attributed responsibilities in this fight. What's the news from Isrrt member societies? Isrrt in the region have got these member societies. What is the news from them? Concerning the national societies of Africa, which are Isrrt members, well, I got information from 6 associations, namely SOSA from South Africa, TARA from Tanzania, SME from Rwanda. And then when you go through all the actions and initiatives that they have carried out in Africa in this situation, well, you come to the conclusion that they have all adopted and promoted the Isrrt COVID-19 guidelines among their members. They also use the social media to train their members and inform them on the situation. And specifically, Tara from Tanzania has partnered with the Radiologists Association to propose government guidelines to be used during imaging procedures. As of Rwanda, well, they organized webinars, 2 webinars which gathered around more than 200 radiographers from Rwanda, from Uganda, Tanzania, and DRC. That is a wonderful action to be done. Well, from Togo, we've got the association ATRIM, from Nigeria, ARN, and then from Cameroon, CSMRR. These are the all associations. There's exactly what I did, what I have already said they also have a reference to the Isrrt publication and research on COVID-19. And then they set online training programs and the participation in online workshops. They're also developing digital tools for learning. In Nigeria, they focus on research. When a young Nigerian radiographer is preparing an article on the situation of workers, pointing out the threat faced by health workers between armed conflict and the COVID-19 pandemic. And then this is something outstanding. Coming to Cote d'Ivoire, the information from Cote d'Ivoire shows that out of 24,370 samples tested, we've got around 9.96% of confirmed cases, 51.88% of healed, and unfortunately 1.2% of death, which comes to 46.88% of active cases. When you come to the death and you want to make a sort of comparison to Africa and the world, well, you will see that 1.2 for Cote d'Ivoire, 2.2 for West Africa, and then 6.52 for the world, for the whole world. But something that we must know is that Abidjan, the capital, well, the biggest city I was talking about, which is the business land, is the epicenter of the disease and the area of containment. And so to face this challenge, the government is upgrading the testing rate from 50 to over 700 tests a day. And with this, you've got the 13 testing centers in Abidjan. 45 decided for, out of 45 decided for the whole country, and is also involving the whole community. There's also an active communication with pastors, a good practice of hygiene demonstration, and green phone numbers so that everyone can communicate on the subject. Now, what is the response from the Ivorian organization, the National Organization of Radiographers in Cote d'Ivoire, that is called INTIMC? Well, we come then, how do we become radiographer in Cote d'Ivoire? You've got 3 levels, okay? The assistant radiographer, then we come to the bachelor, and then there's also a master program. And what are the modalities of practice here? There's conventional radiology, CT scan, MRI, interventional radiology, nuclear medicine, and radiotherapy. The 2 bottom ones are new, but they are on the move now. And the radiographer's career in Cote d'Ivoire is exactly what is done for Isrrt career that has been proposed. You've got assistant radiographer, and advanced radiographer. You see what corresponds to in the Ivory Coast scope. Assistant radiographer corresponds to auxiliaire de santé en imagerie médicale. Radiographer corresponds to technicien supérieur en imagerie médicale. Advanced radiographer corresponds to ingénieur des techniques sanitaires en imagerie médicale et radiothérapie, and consultant radiographer corresponds to ingénieur des services de santé, physique, technology, and therapy. You see, it's exactly something that has planned, and this exists in Cote d'Ivoire since 2015, and that has been really a sort of confirmed by Isrtt's design. For the professional practice in hospital, radiographers fight against COVID-19 by setting guidelines, organizing online training, promoting Isrtt's safety guidelines for COVID, and communicating actively to inform patients and staff, applying also safety measures. For example, in a diagnostic service, they systematically wear gloves and masks, protect the cassette with a plastic cover, clean regularly examination table after the patient, and control panel is also cleaned regularly. They wash hands following the WHO protocol and maintain social distance when communicating. It may be with the colleagues or even for people accompanying the patients. For the patient, they are required to wear masks without exception. They also maintain the social distance of 1 meter for accompanying person of the patient. When speaking to them, they verify the COVID infection status of the patient. If not known, they consider the patient as COVID infected so that they apply strictly safety guidelines, but they avoid stigmatization in case patient is known as COVID infected. This is very important. It's ethical. An example of a radiotherapy center, well, there are 3 sorting stations which are settled. Sorting station and isolation post. The patient to wash his hand before accessing the post. Temperature is taken, and then the patient is questioned to detect clues to his COVID status. If suspect, patient is contacted to the isolation post for the technical team of Pasteur Institute. Pasteur Institute is the local and the national technical service in charge of testing the patient. And then they come to take the patient. If not, he is provided a protective mask. The staff themselves are trained to carry out duties of sorting and isolation of patients. Every member of the staff receives a suitable clothes. The radiographers in this process, they play the role of first contact communicator with patients. They coordinate the activity and they are in charge of declaration of any suspected cases. The challenge they face, the work plan should be reorganized and the workspace to be redefined. You see, as a radiotherapy center, well, things must be strictly respected and everything must be redefined. The shortage of material is the challenge that this goes through all Africa. And there's also the misapprehension of the danger. People don't understand that you shouldn't touch your friend. You couldn't shake the hands of your friend to show him that you love him. This is another part of communication that workers have to do. At the training school, the situation is that all teaching schools closed as of March 16 in the country, which means that no physical meeting with students. The program were only at 20% accomplished. How can we do? How can we reach the objectives? You know that the situation that the school is spread all over the country. So how to be in contact with the students? And at the training school, something important that we can do to help is to use digital tools. Digital tools that can help to train trainers so that they could provide learning from removed part of the country to students. And that's what has been done so that every day there were at least 10 courses, 10 lecturers from students to students who were all over the country. To sum up, I will say that radiographers are the front line in the imaging or even radiotherapy and the last person with the patient before the procedure is made. So they have an important role in communication with the team and patient. They have a duty of care, including protection of patient and staff. It's our ethical obligation to practice according to guidelines for better protection of patient and staff, to ensure education is correctly issued and appropriately indicated, and to educate our members to emphasize the benefits to the patient against the possible risk, and to amend the protocol to ensure quality service delivery with minimal risk. This is very important. The way forward, we know that Africa is a situation, we're generally in a situation where we must do a lot with very few. And so all African radiographers are aware that it is their responsibility to do what they can with what they have, wherever they are. And so what do you do to set partnership for implementation of CBD programs that will be continuing education, to develop e-health strategies, because we know that the traditional process have some limits, to train radiographers to be familiar with digital tools, and then explore new paths towards innovation. Many things have been created. We don't have to create things. We have to infuse a new sense of doing, a new sense of quality by innovating, by adding innovation. And to achieve our goal, considering the professional practice of radiology, which includes patient safety, staff's safety, and then quality service against the COVID-19 challenge, African radiographers and even all over the world, we need mutualization. Something that has been done in Cote d'Ivoire could be shared with the radiographers from Ghana, from Burkina Faso, from Tanzania, and so on. We also need partnership for expert organization. We must be in partnership with them to help our members train correctly. We also need commitments. We must get involved in the practice of our profession. And then networking, to work with Nigeria, work with Ghana, work with Kenya, and so on, and also with Isrrt. And all this is provided under the umbrella, under the leadership of Isrrt. And this, we can achieve it. Ladies and gentlemen, I've been very glad to have this presentation issued to you, and I will thank you very much. But in local languages, I will say midase, aniche, jamo, asante sana. Thank you.
Oh, very well talked from our colleague from Africa, our regional director for Africa from Ivory Coast. I can see you have a lot of fans in Africa. From the comments box, everyone just come here and they are very happy. So I just would like to say, I think this is still afternoon, right? Afternoon in Africa. So yeah, we're gonna have one more speaker from Europe. We are very happy today to have our Vice President, the Isrrt Vice President for Europe Africa from Norway, Mr. Hagon Jamli. For his CV, he's a manager of policy at the Norwegian Society of Radiographers. His main responsibilities for the society are related to professional role development of radiographers and to health political issues. And he has held the position since 2008. He has a master's degree in clinical health, focusing on role development of radiographers and postgraduate education in both digital imaging, imaging processing, and in X-ray protection Prior to the work for his society, he had a variety of roles in both private and public sectors in Norway, including clinical radiographers, QM administrator, manager, radiation protection officer, and also product specialist and sales representative. So very well-rounded person, and very happy to have you today, Hakan. Please proceed with your presentation.
Hi, everyone. Thanks for watching. My name is Håkon Hjemli. I'm Director of Policy at the Norwegian Society of Radiographers, and I'm proud to be one of the presenters for the first Isrrt webinar. And this one is, of course, about COVID-19, and I'm asked to give the perspectives from Norway and from my Society of Radiographers in Norway's point of view. I will minimize myself, and I will start my presentation in a minute. And then we will soon be ready to go. There we are. I'm, as I said, Director of Policy for the Norwegian Society of Radiographers, but I'm also Vice President of the Isrrt. The Norwegian Society of Radiographers, also called Norsk Radiograferbund, we are placed in Oslo. We have an office in the central part of Oslo. We were established in 1973, so we are soon to be 50 years. We are both a professional society and a trade union. We have a hired staff of 9 people, and we have in total close to 3,300 members. And that is also around 85% of all radiographers and radiotherapists working in Norway. Amongst those, we have around 180 local society representatives that are in close contact with our members where they work. And we've been an Isrrt member since the foundation. Here you can see a picture of the president, Bent Ronny Michaelsen. A little bit about Norway. Norway is a Scandinavian monarchy that lies to the north of the continental Europe on the western seaboard. And for many people, Norway is synonymous with oil and fjords, with dramatic and magnificent scenery, from the beaches and the cliffs of the south to the mountains in the middle and the midnight sun, the North Cape. We have a population approximately at 5.3 million, and around 1.2 of those live in or close to Oslo, which is the capital city. It's a very long country. It's the longest in Europe, and our closest neighbors are Sweden, Finland, and Russia. But also Denmark is close to Norway. Our biggest source of income comes from extraction and export of oil and gas. Our government is responsible for providing healthcare to the population in accordance with the stated goal of equal access to healthcare regardless of age, race, gender, income, or area of residence. And Norway also ranks high on the Prosperity Index for Wealth and Well-being. About radiographers in Norway, we have a 3-year bachelor program, which is the most common program in Europe. And around 1/3 of the program is for clinical placement. The program is what we call the combined program, but you will still need postgraduate education in nuclear medicine or in radiotherapy to work independently in those areas. There is kind of a balance in the labor market, maybe a small overproduction of radiographers at the moment, but from my society point of view, we think that this should change. We need to do something about the number of radiographers working in Norway. We do see a small but increasing number of advanced practice radiographers in Norway. We have around 20 reporting radiographers and sonographers at the moment. We also see an increase in research, publications, number of master degrees and PhDs being done by Norwegian radiographers. Here is the World Health Organization global situation regarding COVID-19 for our region. And as you can see, there are big differences in how much we have been affected in the different countries. The dark colored countries have the highest number of affected people related to their number of inhabitants, and the red circles indicate the number of deaths in the same countries. And for some countries, you can see the red dots are quite big, and they also have a high number of confirmed affected people. In total, we have passed 2 million confirmed cases in Europe, and also around 170,000 confirmed deaths. The countries that have been most affected in Europe is so far is Italy, Spain, United Kingdom, France, and we see a big increase also in Russia. The good thing is that there is a decrease in new cases and also in number of deaths being reported. What we know from the statistics is that high portion of the affected people have been healthcare workers, and from all who have died, we know that 97% have had at least one underlying condition. The majority have been men and people aged over 60. The reasons for the variations are many, and they will also be explored, and we will know more about them in a couple of years, I suppose. But we do know that we have big differences in demographics and geography in Europe, and also within each country, that can explain some of these variations. And we also have differences in level and access of health services. Some countries also had experience with pandemics and was prepared with personal protective equipment and planned for actions. And there are also economical differences. Then you have different expert opinions and chosen strategy by the different governments. And there are some insecurity in the statistics because of registration differences in the different countries as well. In Norway, we got the first cases of COVID-19 reported at the end of February. And this was basically Norwegians that had been skiing in their winter holiday in north of Italy. Then on March 12th, the situation was becoming critical, and the government decided to go into a massive lockdown of the country. That basically meant all schools were closed, all businesses that were not defined as critical were closed or had to work or be done from home. You were not allowed to travel, you were not allowed to socialize, all these things, you know, that has probably been discussed in your own countries. Then just recently we started to open up because the situation seems to be much better and under control. But we have had around 8,300 confirmed cases of infected people, and in total 235 reported deaths. But probably the restrictions will last for many months yet, and we are not advised to go traveling abroad until at least late August. And if you do so before that, you will be faced with a 2 weeks quarantine when you come back. Norwegian radiographers have experienced several things during the pandemic, and my society have done a survey to get some data on this as well. And what we found from this was that our radiology departments were not adequately prepared for such a pandemic. There was a lack of national guidance initially. There was a lack of personal protective equipment and training in use of it. There was also a shortage of staff and high use of overtime. We saw this when radiographers started to report sick and was quarantined, that there was nobody to cover for them. And 40% of the radiographers reported that they had to take chances with their own health at work. And as I mentioned, 20% were quarantined during the first month. And also we saw a big increase in general and cancer patients waiting lists that we have to deal with later. But the role of the National Society, we've been all working from home since March 12th. We established a COVID-19 task force that I am part of myself. This was the Center for Communication with our local representatives. We had almost daily meetings to begin with, and recently we have stepped down to weekly meetings. We established a COVID-19 Facebook group for radiographers. We also give trade union support, advice on negotiations, salary, holidays, change of work plans that are related to the pandemic situation. And as I mentioned, we did a survey, and we have engaged internationally on the issue. Then also an important role for the society have been to communicate with decision makers through media and our channels about the role of radiographers in general, and specifically in the situation with the pandemic. And here you can see some of the publications on our websites. This is unfortunately in Norwegian, but I can tell you that there is a link here to the Isrrt guidance on use of protective wear, and also there's a link to the e-learning resource that the Isrrt made together with the EFRS. There are some advice on insurance for radiographers that have been infected by corona. Also on rules regarding regulation of use of overtime, what happens with your plans for the summer, things like that. We also, of course, have political statements from the society focusing on the important role of radiographers, trying to increase the awareness of radiographers towards health authorities. What we see now are, of course, a lot of challenges that we have to deal with. Maybe the biggest one is how to deal with the huge increase in unemployment that we see in Norway. We were at 3%, but now we are around 11% of unemployment. And the government had to use a lot of money to fund some of the results of the restrictions that were made in the lockdown. So we will have poor economy for the coming years. Then we have to avoid a new wave of COVID-19 when we now open up the society, and while we are still waiting for a vaccine. Then there's a challenge on how to examine and treat the increased queue of cancer and other non-COVID-19 patients. We knew, we saw this during the pandemic, that we have a limitation in staff and capacity already before the pandemic. And then with the pandemic and use of personal protective equipment and other preventive measures, we will be less effective than normally to deal with all these extra patients that have been piling up. Then we need to do something about the situation for our students. Clinical placement were basically put on hold when the whole thing started, and this cannot last for very long without having a negative effect on the education of radiography students. Then it is an issue how to raise the awareness and status of radiographers. It seems like it's only doctors and nurses dealing with the pandemic, and that get mentioned in the media. So I encourage you to do what my society did a couple of years ago, to make organize awareness campaigns that highlights the important role of the radiographers. Radiographers take the vital images, and this message was made 2 years ago, but it's even more important now that we have had this pandemic. And by that, I thank you for listening to me, and I hope to see as many of you as possible next year, because the World Congress was moved from this year to next year because of the COVID-19. But it will still be in Dublin, but in August 2021. Thank you for listening.
All right, thank you so much, Hakan, for your informative talk. And before we move on the Q&A session, the audience still have chance to post your question on the comments box down below or on the right side of your screen, depending on which platform that you are watching us at the moment. This is a live broadcast and the first Isrrt Facebook Live. I just would like again to recap what we have been watched so far. I can't say tonight, it's tonight in our Asia time, which should be afternoon Europe, Africa time, and then late morning for you guys in Americas. So we just finished the talk from our 6 speakers from across the world, from our Isrrt 3 regions. Starting from the Americas, we have Mike Kutlas from the US, Mark Given from Canada. From AsiaAustralasia, we have Alexander Chalman or Alex Chalman from Australia, and Naoki Kodama from Japan. And just recently finished their talks. We have our 2 colleagues from Europe, Africa, starting from Boniface Yao from Ivory Coast, and then Hakon Jamli from Norway. You can obviously see that we are so diverse across the world, but it doesn't matter. The way we practice, we are unified in one profession as radiographer or radiological technologist, depending on how would you call your profession. In terms of the pandemic, we can see that different countries already passed the first wave, and some countries still struggle to climb up for reaching the peak and then hoping that the pandemic will calm down. It is obviously seen that our profession, radiographers, is the frontliner profession. We have a lot of people on watching the show here posting the question. This is very tricky for me. Maybe I just asked for some comment from the panel here, because we know by heart that radiographers and radiological technologists, we are frontliners profession in the clinical environment, but people in some places, they would like to see a document to prove or to show to the related authority that we really are. So what can be a comment? This is quite tricky. So let's start with our colleague from Europe then, Hakon. Since I see you smile.
I'm always smiling. Can you hear me?
Yes.
Yes. I have to ask you to repeat the question. What was it that you said you wanted me to answer to?
This is not really a question, but I think it's rather a comment, because it's quite tricky situation when we know by heart, by the way we practice, that we are frontliner profession in this pandemic. But our colleague from different places post on their comment box that how can we prove any documents for it?
Well, no, I'm afraid I don't have any document arguing for that we are in fact frontliners. But I think patient survey would quickly answer that question and give you some good proof on that. We all know that we are, and it's a shame that we have to argue for our visibility, but it tells me that we are maybe too humble. We have to start tell people who we are. We have to say that we are radiographers when we meet our patients. I don't think everybody's good enough doing that. One other thing that I would like to mention when I have the word is that I mentioned in my talk that we have quite a lot of resources in Norway, and we have a decent standard of our healthcare. But the standard and the money doesn't matter if you don't have a good plan on things. And what we experienced, what we learned was that we thought that having money in the bank could save us when we come to a crisis because we could just buy what we need then. But that happened all over the world. So there was nothing you can buy because everybody was competing about the same PPE equipment and medicine. So we really learned now that we have to have our own storage, or we have to start produce such things ourselves. And that may solve the arguments that we have had to have with nurses and doctors, because people were really fighting about these things. I'm more important than you. I need this PPE. You cannot come here and take it from our department. This happens because you have planned too badly.
Yeah, I do agree with you. I myself, I'm the president of Radiography Board of Thailand, and we had a big fight because the nurses and the doctors, we didn't really fight with them. But the point is, when it comes to the time when we don't have enough PPE, and especially the surgical mask or the N95 mask, I think we need someone to speak up. Everyone is important in your profession. And when we take care of the patient, we come as a team. But to make our profession stand out, we have to have someone advocate to do it. So let's go back to our president and see what she says, Dana.
Hey, can you hear me? Okay. I thank you for the opportunity to address this. I do want to say that in our document that we have produced, which is on www.isrrt.org, under the COVID tab, are guidelines for practical advice during the COVID crisis. In the beginning of the introduction, we do define ourselves as frontline workers. So I do know that we do have that in there. Maybe we need to go a step further and have a position statement. But if you need something at hand today, go ahead and go to the ISRT website and download that document on the COVID page. And you'll find that in the beginning paragraphs as listing us as frontline staff workers. And I agree that we need to continue on this line and promote ourselves more.
Thank you, Madam President. Well, let me have one more person talk on this. I think Boniface will be a good person because he represents Africa, our big group of radiographers practicing in the moment.
Do you hear me? Is it okay? Well, okay. I think that radiographers in Africa, or from everywhere, they are aware of their responsibility. They are aware of their responsibility to go and to search, because they know radiography. I think radiographers know that. So, well, you can have all the documents from ISRT, from IAA, and so on, but you just have to do something with it. It means you must go to set partnership with institutions and so on. And ISRT is our backbone, is our association, which is known, is the voice of the radiation technology, which is known from everywhere, so that we can do all that. And that's what we're doing here in Cote d'Ivoire, trying to set convention with institutions to train radiographers, to use online equipment, online tools, and then to train them in city for risk management and everywhere. Everything that we can do, it is possible. We just have to know that we can do it. I mean, our responsibility. And I think this time things are really going on well.
Thanks a lot. I think this issue, I think we as the international organization representing 500,000 of us need to step up and do things, and in response to the request of the member, maybe we get some voices from our two colleagues from the US and Canada also. Let's start from Mike.
Yeah, I think, a couple of thoughts. First of all, we're talking about things on a very macro level, a very, either countrywide or internationally, and that's important. But just as important is the micro level and the smaller levels. And as I said in my presentation, our focus really on healthcare in the United States is at the state level. And as painful as it is, we try to keep up with what's going on in 50 different states and in what's going on in the national government. So if there is legislation, if there's some sort of a push in a state for frontline workers, we would call them essential workers in the United States. But if there's a push to get them hazard pay in some cases, protective equipment, anything like that, we want to make sure that we have a seat at the table. And so if that legislation is going through and we don't see radiographers and radiologic technologists there, then we make the case that they need to be there. And that takes a lot of work to keep up with that. But also at the individual institutional level is providing that education and making sure that the hospital administrators understand what we do. So it's very complex, as you said, to start with, Napapong. But the one thing that I hadn't quite heard yet is keeping our eye on the legislation that's going through, making sure that we have a seat at the table.
Very good idea. I think we need some comment from Canada also, Mark.
Yeah, I'd be more than happy to do so. In the Canadian context, it's been a real fight for us to be seen as frontline. So a lot of it has to do with documentation. We've been writing letters to ministers. We've been writing letters for unions to support them to get access to things like pandemic pay. Our provincial associations have done phenomenal work on the local scene as well. But when Mike was talking about the micro level, I think the micro level also goes down to the radiographers and the MRTs on the front line. And one thing that we're horrible for doing is not introducing ourselves, what we're going to do and who we are. So if you start off with, my name is Mark, I'm a medical radiation technologist, I'm going to be doing your MRI today or X-ray today or your radiation therapy today. Let's get those started and let's start raising that profile from the ground up. The association's Isrrt does a phenomenal job of getting messages out at the national, local levels. We have to do it, but we need to start on the front lines and get that done as well.
I absolutely agree with you, because once if you keep your mouth closed like this and just go to service your patient without letting them know who you are, and especially even people inside the hospital, other profession, we have to let them know how important we are also. We are part of the team. So maybe one comment from Japan, a very strong man from Asia. Do you have any comments on this, Dr. Kodama?
Hi. Now in Japan, so midnight. So now in the May 1st. So last year, JRT issued a guideline regarding infection in the radiological technology field. So this year, Japan Radiological Society notified the member of the recommendation for the radiological sector during the COVID-19 pandemic. In Japanese situation, it is not necessary to wear full PPE in daily practice. However, if patients have cough or suspected pneumonia, we should wear it. So in Japanese originality, have a behavior of wearing a mask, and I think that it can be synchronized with the national character of the Japanese people. So the Japanese are good at keeping a distance from other people. Thank you so much.
All right, Dr. Kodama. Let's move to the next question. I think it's quite late for you, Kodama, but maybe we stay a little bit longer. I got a very interesting question from our audience from Shedi Olawa. Sorry if I pronounced your name incorrectly. The question is, the ISRT appears to have good professional relationship with the IAEA. However, it appears that the radiation protection of patients of the IAEA, RPOP IAEA, do not really know what we do. Most of their publication appear to give the credit to the work, radiographers and radiology technologists to the medical doctors or the physicists. Sometimes radiographers are referred as technicians and don't even receive any mention. I think Donna Newman, the president of ISRT, should have a very, very good answer or feedback for that regarding what we have done so far.
I have to tell can you hear me? I have to tell our members and everybody that are watching that we have a really good relationship with the IAEA. We are always officially invited whenever a document is being done related to our profession, because we are the official NGO in relations with the IAEA. We are moving forward and we are getting our name in those documents. They call us, they invite us to all the conferences that are happening. So I would have to say that I do not know what has happened in the past, but as long as I have been on the ISRT board, we have been invited first and foremost to represent our profession. As president, I always send a person with expertise in that area related to the topic so that they can actually input to the document and give accurate information. So you will see the documents being produced now. They have the radiographer's voice in them. The BSS safety series does. I just participated in an IAEA COVID document with the IAEA where we were invited to represent nuclear medicine at that meeting, and they came and asked us right away. So I believe that we are being asked and we do have expertise to have input to those documents. So I am not sure where that comment is coming from. That may have been something in the past, but I don't agree that that is how we are seeing it at this moment. We sometimes cannot affect that we're called technicians. Sometimes the ILO documents refer to us as technicians, and in official documents, we have to be referred to by the definition in the document. So we are moving to try to change that, and we will have to change that at the ILO position before we can officially have that changed in documents. But we know we're radiographers, we know we're radiologic technologists, we know we're radiation therapists, and in all of our documents, we put that in and we push for having that in wherever possible. Thank you.
Oh, thank you, Madam President, for this clarification. Actually, we have done a lot during the past years for promoting our profession on global stage as the ISRT represent you across the globe. I got one interesting question from a couple of people who are watching this program here about, we're all talking about radiographers. What about radiation therapists? We have colleagues in radiation therapy and they ask if we have any documents supporting them because during COVID pandemic, cancer patient cannot wait. Radiation treatment might be their last chance that they get, so they cannot wait. So they just would like to know if we have any document to support them. Maybe Donna, you can answer this.
I'm very excited to share with you that if you go to the ISRT COVID tab and download the guideline for practical practice and COVID, you will find on page 71 through 77 guidance for radiation therapists. When you're treating a patient with that does not have COVID versus a patient that has known COVID, good information about what to do for the whole department, staffing, and we had really great input from experts from the UK and experts from on our board and around the world that actually helped develop this section. So if you're looking for information on that, please go to that guidance document. We also have an e-learning module that will be coming out in a week that you will find on our e-learning platform on specific to radiation therapy. So be watching for that announcement and for the information, and you will have some very good education and information on radiation therapy in the near future on our e-learning.
All right, thanks a lot for your answer. I think the time is very tight now. We have run this program for quite a lot, and what the ISRT also need from the audience is that the suggestion of the topic. Well, I'm very excited to tell you that we are preparing the coming of a series of webinar for you, and then we will announce on our website and also this Facebook. And before closing the program today, we know that COVID will be with us for a while, and we're gonna have something called new normal, right? Everybody talk about new normal. I just would like the speakers here today or tonight or this afternoon, wherever you are, just give the final word or some message to our colleague around the world about what kind of new normal in terms of professional practice in your perspective, and that's going to be your message to them. Let's start with Mike.
Sure. I think the new normal is adaptability and flexibility. Every time we try to come up with a plan, try to figure out what to do, it seems like things are changing constantly. So, we're in a really, really good situation as radiographers because flexibility is part of our DNA. And I think we can really be a positive influence in all of healthcare and a positive influence to our patients because of that flexibility. So I think that's the new normal. That's the word that I'll put out there.
All right, thanks, Mike. And next, move to Mark Given from Canada.
Yeah, picking up on what Mike spoke about, I think it's going to be really important for us to be parts of the collaborative teams going forward. I think it's time for medical radiation technologists or radiographers to integrate themselves into the medical team at a much higher level and to really advocate for us to be on the front line. The social distancing materials and everything is going to be in our new normal for some time to come. I think this is an opportunity for MRTs to get their voice heard, both at the provincial, local level, national level, whatever that case may be. But it also allows us to be super innovative and to really change our practices to advance the model of care for ourselves in imaging and in radiation therapy. The radiation therapy modeling materials that have been covered here in Canada have been phenomenal, how they're modifying patients' protocols and getting the throughput through to make sure that nobody's being left behind. And I think it's really important for us to advocate for getting our services ramped back up and to get them moving at a most safe and efficient rate as we can.
All right, very, very good idea. So let's move to Hakan.
Yeah, well, new normal. Well, that's not so easy to give a good answer to on the fly. But I copy what's already been said, and I think such a global pandemic that we have all now experienced and are experiencing, and would probably be experiencing for another year or so. It unites us as professionals. We see the same challenges all over the world, and we connect more than ever before. And we discuss this, and we do webinars like we do now, and we will also survey this, and I'm sure we will make good position statements based on this too. It will make us all stronger, I think. And as was just said, we can use this for our benefit to be more visible as well. So hopefully that's the new normal. Thanks.
I think everybody has their own new normal. All right, let's move to Boniface. I just see you come back. That's why I let Hakan speak first. Please unmute your microphone.
I probably missed a lot of things because there was a challenge with my connection.
Oh yeah, we just talk about the new normal. So in your perspective, what is the new normal after this COVID pandemic that we have faced and we are facing, and we're gonna face with this COVID for a while?
Well, while we're thinking for the perspective, I was just talking to you about the technology of nano service, because one of our challenges here is internet connection. When we work with our students, or give them of connection. So we are working with the startups on this nano service which can help students access to our platform and have resources without internet connection. And for the radiographers themselves, for the professional practice, for the development, we are setting convention with an institution, a continuing professional development institution in France, to train them regularly. And I think this experience that we've got with Isrrt, I think this is going to be implemented so that we can have in African region regular training on Facebook. That will be something wonderful that we could promote.
All right, for folks in Africa, you will hear something from Bana first. He's planning big things for you, so let's stay tuned for that. So before Dr. Kodama, before your bedtime, let you say something to close this program.
So new normal everyday life has begun in Japan. Maybe it has to coexist with COVID-19. It is necessary for academic society and the professional organization to take a great leadership and rule to prevent the hospital or clinic and medical care system in Japan. Thank you.
All right, so we still miss Alexander Chelman, but you have to understand this past her bedtime. So her time may be 2 a.m. in the moment, so she sent an apology, but we feel grateful for her for joining us for this program. Oh, well, I think it's time for us to close this first Facebook Live for this Isrrt Facebook. I would like to thank Mike Kutlas from the US, from Isrrt, and Mark Given from CAMRT Canada, Alexander Shellman from Australia, from Isrrt, and Dr. Naoki Kodama from JART, from Japan, and Boniface Yao from Ivory Coast, and Hankon Jamli from Norway. And special thanks to our president, Donna Newman. Maybe we have our Madam President has a short closing speech.
I just want to say to everybody out in the world is much smaller when we can communicate electronically. And I think that we have shown today what great experts we have around our societies. And we believe that this is a great format for getting information out and sharing our expertise in our field. So please, all of our members, let us know what you think of our Facebook Live, give us suggestions for new topics. And please let us know what we can do to meet your needs as our members, because the Isrrt is your global family. We are here for you. And thank you very much, Napapong and Yudapong, for putting this webinar on and helping facilitate it, and for the speakers for taking time to put the information together and share with our members. Thank you.